So again, we're discussing acute diarrhea. One thing I'd just like to comment before I get started is I really want this health forum to be very laid back. I want you to feel comfortable asking questions and it being a discussion commentary during the presentation. So please feel free to do so during the talk. So as I said, in regard to acute diarrhea, it is the second leading killer, as we will learn, in the pediatric population. So it is a vitally important topic. And when we think about it here domestically, we don't think about just the magnitude and the potential fatality and impact it can have, but indeed it is tremendous. So it's something that, again, we need to learn about. Dr. Tom Wood and myself, we just returned from South Sudan, and this was a cute little couple, boy and I guess they're both small boys running around playing and quite happy, as you can tell, and relatively stable. But as you well know, children like this in the developing world, should they acquire an infection of sorts that can cause acute diarrhea, they can become debilitated very profoundly, very quickly. I like this picture here. I've used it before, and if you were at the simulation, this talk is in part from that, but I've modified it quite a bit. But I like this picture because it just displays so poignantly some of the characteristics that we find with a child that has been decimated by acute diarrhea. And you can tell, you don't have to have MD after your name, this child is profoundly dehydrated, which is one of the leading causes of demise associated with acute diarrhea. You can see this caretaker has just evaluated for skin turd or skin pinch on his abdomen, and you can see that it doesn't return readily, insinuating that he is profoundly dehydrated. You can see that his eyes have regressed tremendously, and you can look and see that he up here he's got temple wasting, and so there's a number of signs, and he's just prostrate and fallen out. He's virtually unconscious from just profound dehydration. So that's certainly one of the issues associated with acute diarrhea, but it is a leading killer. Again, I've got written there, it's the second leading cause of child mortality in children under 5, U5 children. Certainly in a refugee setting, that sort of the environment is the perfect storm for an outbreak of various infectious diarrheas. And I should state that virtually always in the third world or developing countries, the etiology is going to be infectious. Certainly domestically, there's other causes of diarrhea, whether they are from lactose intolerance, celiac disease. There's a number of things that can cause non-infectious diarrhea, but in the international world, of course, it's infection, infection, infection. We see there that 4.5 billion episodes of diarrheal illness occur every year worldwide, and it is, again, I've said this several times, it's the second leading cause of death in children under 5 worldwide. Every year that goes by, 1.5 to 2 million children succumb to diarrheal illness. The thing that's so important to stop here, and I'll just emphasize this, and I know Dr. Wood is very motivated to address this issue. This is a completely preventable illness, and so this is something that you and I, as humanitarian medical humanitarians, we can intervene and make a huge impact. So that's why it's so critical that we do continue to study diarrheal illness and determine what are the simple interventions that we can take to prevent these deaths. So to get started, acute diarrhea, there's ways to break it down or categorize it, and I've done so here. This is very important, both in recognition as well as diagnostic purposes. So we can see here that there's acute watery diarrhea, invasive bloody diarrhea, and then chronic diarrhea. And by definition, chronic diarrhea is usually anything that lasts for greater than 14 days. For the purposes of this talk, we're going to focus on the first two, acute watery diarrhea and invasive bloody diarrhea. And again, it's important diagnostically because there's different organisms that are associated with watery diarrhea versus invasive diarrhea. Invasive diarrhea will also, synonymously, you can refer to that as dysentery. But there's different organisms that cause acute watery diarrhea versus dysentery. So we're going to look at that. And there's also treatment, important implications in terms of treatment. So that's why it's important to make this distinction. So again, I've already said this, but in looking at acute diarrhea in the developing world, it's almost always an infectious etiology. You certainly should be vigilant for other non-infectious causes, but almost always it will be infectious. And it's usually due to a primary infectious gastroenteritis. In other words, an organism that directly infects the gastrointestinal system, such as E. coli or Giardia or Cryptosporidium. We'll talk about those in a second. So it's usually a primary infectious gastroenteritis. But don't forget about other systemic illnesses that can cause diarrhea. For example, a very obvious one would be HIV. But others, systemic illnesses, can cause diarrhea, and so you kind of, you know the old expression, you can't see the forest because of the trees. So be real careful. Like for example, malaria, it definitely can have a strong GI component with diarrhea. Measles can certainly cause have an associated gastroenteritis and cause diarrhea. Even pneumonia, pediatric patients with pneumonia can have diarrhea associated with it. The treatment that we utilize, antibiotics, are certainly associated with diarrhea. So don't forget about systemic illnesses and side effects of our treatments. Also remember intra-abdominal surgical emergencies. Intussusception can be associated with diarrhea. Megacolon, perforation, these are other things. So be vigilant for an acute abdominal if you have an acute abdomen as well. Any questions as I move along? Don't be afraid to speak up. So risk factors. What are some risk factors? As I said, a refugee camp, that's unfortunately, that sort of creates the perfect storm because if you look at these risk factors, they're all very readily found in a refugee camp setting or an IDP camp setting. So, of course, when you have that many people in a concentrated area, you can't help but have some component of poor sanitation and hygiene. We certainly work hard as an organization to prevent that. We take measures, educational measures, and interventions to create improved sanitation and hygiene, but that's certainly a real problem. Inadequate clean water supply. Janet Ossel is with us today, and she knows that's a very difficult challenge in a refugee camp setting or in any developing world setting. There's just often very poor clean water supplies. Patients or I should say, the population often relies on surface water. That's their only source. We say don't use surface water, but if that's your only source, that's all you have, and it's often contaminated.
Lance, in that, and if you'll recall our visit to the Doro refugee camp, in the interviews we had with the young ladies there, was very telling in that one of the young ladies very definitely knew what we were looking for when we asked her the question about where she procured her water for her family, and she said at the boreholes. The other young lady who was a little bit more upfront, both in her demeanor and her approach, was very open about the fact that she got her water from an open water source, and with a little discussion that went on among them at that point in time. It was interesting. We would ask a question, there'd be a great discussion, then we'd get an answer. But the discussion took place, and the first young lady admitted that if the line was long at the borehole, that she would frequently take water from the surface water supply as well.
Right.
One lady in the group walked over and came out with a little, pan of water, and she says, "This is our drinking water," which was very heavily, a lot of river and surface influence in what she brought out. So even if they do have the boreholes available, whether or not they go to them or whether or not they'll wait in line, at those boreholes is a whole different thing. So we're dealing with a cultural thing there as well.
Right.
And then the other thing we noticed at that camp is that they had a hepatitis E outbreak in full swing. Which is a sanitary disposal of human waste problem. That they had refurbished all of the the latrines around each one of the camp centers. It was interesting the way the camp was laid out. But that in all of them, all of these refurbished latrines and the hand washing stations that were present, and the entire time that we were there, we did not see one of them in use.
Right.
Not one. So they're there, and we can provide them, but we're also dealing with a huge problem with culture.
Yeah.
And then adapting or modifying culture.
Yeah.
And even in the midst of a hepatitis C outbreak, there's a very big one going on. They're still reticent.
Right.
Or chose not to use both either the water source or the sanitary.
Right. So sometimes it's not even acquisition, as Tom's appropriately describing here. I mean, sometimes they have latrines, they have clean water sources, but for various cultural reasons. In fact, while I was there, I learned that there's a number of persons that are really apprehensive to use the latrines. They have a lot of fears about being in an enclosed, dark area. It makes them fearful, and we're overcoming, centuries of, people defecating and utilizing open fields and so there's a lot, there's a lot of educational issues for sure. Other risk factors, obviously overcrowding, and then certainly malnutrition. Anybody that's malnourished, they're certainly at much higher risk. They have compromised immune systems, and their gastrointestinal tract is less resilient, if you will, and they're more susceptible to acquiring diarrhea from various reasons. And then whatever the reason may be, whether it be malnutrition or HIV or just various reasons for immunocompromised state, they're certainly at higher risk too. So these are just several of many increased risk factors that we see in the third world that make these people quite vulnerable to various infectious diarrheas. This is just a quick advertisement. Tom and I, like I said, we just got back from South Sudan. We visited various venues in which we're intervening there in South Sudan. This is in AKUEM, which I believe is in the northwest region of South Sudan. Yeah, northern Barghazal, not too far off from the border. This gentleman that we're with there, Sudanese gentleman, he's one of the primary, clinical workers there for the tuberculosis campaign that they have going on in Boonge Hospital, which is, I'm thrilled to see that we're Mary Lou, I'm sure you're excited to know that we're doing that. So that program is up and running. So in terms of clinical assessment, this was, evaluating the various signs and symptoms when you evaluate someone with acute diarrhea. This was a simple methodology that I read about that I like the way they broke it down. It's just an easy, standardized methodology for assessing someone with diarrhea. So initially, you want to classify the type of diarrheal illness. And again, we broke that down into acute watery diarrhea versus acute bloody diarrhea or dysentery. And again, usually just it's a bit arbitrary, but after 14 days, we call it a subacute or chronic diarrhea. So you want to classify that because, again, as we will learn in just a moment, it's really important because certain organisms are associated with acute watery diarrhea, and certain organisms are associated with acute bloody diarrhea or dysentery, and the management is going to be different. So after we classify the type of diarrhea, and you also, just to elaborate a little bit more about that, you want to, go into detail. I mean, what's the extent of their diarrhea? Are they having 2 or 3 loose stools a day? Are they having 10 to 15? What's the appearance? Is it, for example, if it's bright green, that makes you think about, like, for example, rotavirus, bright green and without blood, or if it's rice water stools. I'm sure many people, what does rice water stools make you think about? That's exactly right. Make you think about cholera. So you want to have a descriptive of the diarrhea and the quantity and the what does it look like? So that's important. And after classification, you want to go into assessment about hydration and electrolyte status. And I have a slide dedicated to that in just a few minutes. But there's a number of things that you can, look at, and a picture is worth 1,000 words, especially, like, for example, in cholera. You can tell in a second. You look at them, you can see they have regressed eyes. Their eyes are very sunken in, and they'll have temple wasting. You can see that on the side of their head. Their skin turgor is very, very poor. Their mucous membranes are going to be dry. Actually, they kind of go through a phase where they, their thirst initially is enhanced, is increased, but at some point their level of consciousness starts to diminish, and their instinct for thirst diminishes too. So anyhow, those are some things, quick clinical assessments that you can make. Now, in terms of electrolytes, usually we're not going to have the luxury of looking at quantitatively looking at electrolytes, but I can just tell you that these patients are going to be depleted of potassium, and certainly probably magnesium as well, and some other electrolytes. But in particular, I'll focus on potassium because that really can put you at risk. In fact, one of the articles I was looking at, it said that in severe acute diarrhea, up to 10% or higher of the mortality rate can be attributed exclusively to hypokalemia because, of course, initially they'll present with muscle weakness. They can get into an ileus associated with like a paralysis of their gastrointestinal system. And then they can really get into trouble, and then they can, of course, get cardiac arrhythmias. So that's something that we have to kind of use our gestalt and treat empirically, but that's something to keep into consideration. And then, of course, assessment of nutritional status we'll talk a little bit more about, too, but that's very important. Some of these patients that are profoundly malnourished, you want to be very careful how you treat them. With regard to rehydration, you want to be a lot more conservative, because patients that are malnourished, they're going to be more susceptible to volume overload, so you want to be especially careful with utilization of IV fluids. And also patients that are profoundly malnourished, you basically, even with acute watery diarrhea, we would utilize broad-spectrum antibiotics. So we want to assess their nutritional status, that's important. And then also we want to look for comorbid conditions. Some of these diarrheas can cause comorbid conditions. I'll give you a few examples, like, for example, Shigella is associated with encephalopathy and seizure disorder, or, as we know, E. coli, O157 is associated with HUS, or hemolytic uremic syndrome. Some of them can cause bowel perforation, and others, there's a number of comorbidities. Let's see, I think I've already really covered a lot of this slide, but this is put out by the World Health Organization, and these are 4 clinical features that we can utilize to quickly assess someone's hydration status. And again, I've gone over those, but just general appearance. Do they look well, or are they restless or irritable? Are they very lethargic and unconscious? So general appearance. Number 2 is looking at their eyes. Are they normal, or have they sunken in, or they regressed? And then thirst, like I said initially, they get very thirsty, but then with time, eventually their thirst diminishes and they're unable to drink. And then we talked about skin pinch or skin turgor. When someone's well hydrated, you pinch their skin, the elasticity and the hydration enables the skin to return quickly to normal, but with impaired hydration, it starts to go back slowly and then even more slowly. And then finally, you can make an estimated, you can estimate their fluid deficit. If it's relatively close to normal, then it'll be less than 50 milliliters per kilogram. If it's a moderate degree of dehydration, that is 5 to 10%, they'll have 50 to 100 mLs per kilogram fluid deficit, and then if they're severely dehydrated, it will be greater than 100 ml. So those are four features that you can look at for making a very rapid assessment of their hydration status. Okay, we've come to a poll question time, and I'm going to turn this over to Rich and let him conduct this part.
All right, like many of you have done before, our polling type is answered in our participant window, and you can see there that Lance has 4 choices for you. So if you'll look just in the participant window, just probably above Lance's name or your name, you'll see a little box with an A in it, probably somewhere over in this area of the screen. So go ahead and register your answer there to his question about acute diarrhea, and look at that little box with the A around it and roll over it, and you can choose your A, B, C, or D answer again. Look in this area of your screen. You should see that little box above your name in the participants list. We'll give you a moment to do that. Chad, I can see you registered your vote. Thank you.
All right, that's good. Huh? What's your vote? Okay, I'm glad to see there's some varying answers out here. So actually, let's see, I got to remember which one. Let me read the question.
So let's see, Dana, Elaine, Jerry, you guys could vote in our poll. Mary Lou, and again, that's just by selecting the A, the little box in it, and selecting your coordinating response. Just roll over that box and you can select A, B, C, or D.
So actually the answer, and it's a little bit, there's a little discussion, but actually the answer is D, is only in acute bloody diarrhea. Just to elaborate on that, and we'll elaborate a lot more as we go along, but there are a few exceptions. So remember, in general, in acute watery diarrhea, we generally do not utilize antibiotics. There are 2 exceptions that I can immediately think of, but the general teaching is in acute watery diarrhea, we do not utilize antibiotics. And then it says C, only if the diarrhea is severe and lasts longer than 3 days. Like I said, I can think of 2 cases of acute watery diarrhea which are exceptions. Can anybody name what they would be? Cholera is definitely one of them. Yes. So cholera is one of them, and who can think of a second situation where you would have acute watery diarrhea and you should use antibiotics? Anybody can think of that? It would be profound malnutrition. So in a patient that has profound malnutrition, even if it's just acute watery diarrhea, they do recommend broad spectrum empiric antibiotics. But in general, again, to answer this question, usually we would only treat acute bloody diarrhea with empiric antibiotics. And we'll discuss that further as we go along. So in terms of the diagnosis for diarrhea, usually in the developing world, when we're treating patients, we're going to make the diagnosis clinically. Now, there are situations where it would be preferable to make confirmation with culture. For example, if we're in a refugee camp setting and there's a big epidemic of a diarrhea, it would behoove us to know the causative organism so that we know that our treatment regimen is directed and very appropriate. When we're thinking about the diagnosis, there's a number of causative organisms, which we'll briefly discuss here. Number one, and the one that we would often be most concerned about, would be bacterial, and there are types that are non-invasive bacterial infections, like, for example, in general, cholera tends not to be invasive, and then there's intero-invasive, such as Shigella, which is very invasive. And then, so that's one. Number one, there's bacterial causes. Number two, there's viral causes, such as HIV is certainly a cause of a viral cause of diarrhea. Rotavirus is another one that's tremendous. Norwalk. So there's a lot of viruses, and rotavirus is one that is very, very common in the pediatric population. So think about that. And then certain protozoal infections. One that we'll see two that I can think of immediately would be Giardia and Cryptosporidium. That protozoa can cause diarrhea, and then amoeba. And certainly the one that we see by far the most is Entamoeba histolytica. And that causes amoebic dysentery. So those are the types of organisms that we can encounter. Now, I've created a list of organisms, and you don't need to necessarily be an expert on all these various organisms, but it would be to your interest to be as familiar with them as you can, because each one kind of creates a fairly distinct clinical situation, and each one can be potentially associated with various complications, and there's different treatments for different organisms. So again, oftentimes we're not going to have the luxury of diagnosing the exact organism, but it's important to know what they look like clinically. One thing that's important with, this is the list of organisms associated with acute watery diarrhea. And again, with acute watery diarrhea, we're not generally going to utilize antibiotics, and we would treat much of these organisms in the same fashion. So that's one thing that is one element that's to our advantage here. But I'll just name them. I'm not going to talk about each one individually per se. There's E. coli, and there's different types of E. coli. You can see here there's enterotoxigenic E. coli and enteroaggregative E. coli. These both cause acute watery diarrhea. But in just a second, we're going to look at the list of dysentery, and there's a couple of E. coli on that list too. So E. coli is associated with acute watery diarrhea and invasive or bloody diarrhea. And then there's Campylobacter, which can cause acute watery diarrhea and dysentery. And then there's Vibrio cholera 01 or 0139, and almost always the one we're going to see is this 01. Like in Haiti, we encountered El Tor, which is a subtype of 01 Vibrio cholera. And again, that causes rice water stool, so it looks very milky, and it looks like it has little rice fragments in it, which is shedded mucosa. And then there's this Aeromonas species, which truthfully I don't know a whole lot about. Then there's this non-typhoidal Salmonella enterica. There's a lot of different types of Salmonella, but this is the non-typhoid subtype that causes acute watery diarrhea. And then there is an enterotoxigenic Bacteroides fragilis, and then there's a norovirus. So again, you don't have to be experts on all these, but it's good to be at least familiar with them. And then looking at acute bloody diarrhea, again, that is, you'll hear exchangeably dysentery. And this is the invasive types. There's enteroinvasive E. coli or enterohemorrhagic E. coli. Enterohemorrhagic E. coli is associated with HUS, hemolytic uremic syndrome. One little, I guess this is just a little tidbit of information that's important to remember. So enterohemorrhagic E. coli is associated with the HUS. When you see that with E. coli that causes HUS, actually antibiotics are contraindicated, which is unusual. Now, there are other organisms that can cause HUS syndrome. for example, Shigella with Shiga toxin, that can cause HUS type syndrome too. And in that situation, you should treat it with antibiotics. So again, it's important for us to be familiar with these organisms. But so there's, just to read the list, enteroinvasive E. coli, enterohemorrhagic E. coli, Campylobacter, which again is on the acute watery diarrhea as well as acute bloody diarrhea, Shigella, and Shigella is the most common invasive bacterial infection that we will encounter. So we'll see this Shigella dysentery subtype 1 very often, especially if you're in a refugee camp setting. If you see bloody diarrhea, high chances it's Shigella. And then Entamoeba histolytica, or amoebic dysentery, and that looks clinically very similar, if not identical, to Shigella. But it's important in that we use a different antibiotic for that. We'll talk about that in a minute. And then Schistosoma mansoni can cause, so schistosomiasis, don't forget that. In South Sudan, for example, that is endemic for schistosomiasis, so you need to keep that in mind. And then, again, non-typhoidal Salmonella enterica. So for all you infectious disease buffs out there, you should become familiar with those lists. Any questions about that before I move on?
Yeah, I think it's, as Lance has said, it's very, some of the things you need to keep in mind are the clinical pictures that come with this. I'm thinking of Entamoeba histolytica in particular. You will get the bouts of bloody diarrhea, but they will be intermittent with periods of constipation.
Right.
So, that's a picture that you look at, and if it's a varying picture between constipation and the diarrhea, then, you go to look at histolytica as a possible
right. And just for example, just to kind of drive this point home, it's important to be familiar with these different organisms too, because again, each organism can be associated with different complications. Since we're talking about, for example, Entamoeba histolytica, that, as you all know, is the same organism that causes an amoebic abscess in the liver. It doesn't happen often, but it can happen. And so that's important to know if you suspect that they have an abscess of the liver. If you see that on ultrasound, for example, we're definitely going to have that technology with us on a number of deployments. So if we see an abscess in the liver, then we certainly should think about Entamoeba histolytica. Okay. So getting to the treatment of acute diarrhea, and again, the real salient point here that I need to drive home over and over, even if you guys, I don't want you to be intimidated, like, for example, by all the various organisms, because that's a lot to digest, a lot to remember. But the really thing, if you can just remember some key principles of treatment of acute diarrhea, you're going to be able to help the vast majority of people and prevent so many of these people from dying. So with simple treatment intervention that we can use ourselves or we can teach others, I really encourage that we do that we teach, like, for example, village healthcare workers, when we go out, we can leave an education behind that will last a lifetime. So looking at the various modes of treatment, early rehydration is critical. And remember, if you still have a patient that is capable of oral ingestion, that's the route to go. You want to treat them with ORS. One thing to remember, we'll talk about this also, if you have a patient that's profoundly malnourished, you would prefer to use an ORS that has less osmolarity. For example, the, what's it called, Racemol is a commercially available ORS solution that has lower hyperosmolarity, so that you don't put these profoundly malnourished patients into fluid overload by giving them excess salt. Again, number 2 there, you see electrolyte management. Again, we're not going to be able to measure their potassium levels, but things that you can do, ORS has not a lot of potassium, but it does have potassium in it. There's some solutions now, for example, Ringer's lactate, I would think is an ideal solution if you're going to use IV fluids. It does have potassium in it, And there are some solutions that are specifically designed, for example, for cholera, because you lose, in cholera you lose volumes and volumes of fluid through vomiting and diarrhea, so you're going to lose tons of potassium. They do have some solutions that are called cholera saline. Normal saline does not have potassium in it, but cholera saline or Ringer's lactate does have some degree of potassium in it. So in Haiti, when we had the cholera treatment centers, we had a protocol, and I'll refer to the protocol that Mary Lou Fisher and myself put together. There's an empiric regimen there that you can give people supplemental potassium. If they can start to begin to eat again, you can give them potassium through bananas or various forms of fruit. So I would give these people, you're way more likely to undertreat them with potassium than overtreat them. So I would encourage you to, within reason, treat them for hypokalemia or low potassium. And again, number 3 here, and this is an important point. That was the questionnaire that we just conducted. We generally, as a general rule, we only use antibiotics in acute bloody diarrhea. In acute watery diarrhea, just with the management of fluid and electrolytes and nutrition, those patients tend to get better without use of concomitant antibiotics. Again, there's 2 exceptions I can think of. Cholera, you do use antibiotics, and severe malnutrition, you do use empiric broad-spectrum antibiotics. And then zinc supplementation, nutrition. We'll talk further about zinc supplementation in just a minute, and then nutrition management. And some of these patients, many of these patients, we can treat on an outpatient basis, but some we would require hospitalization. I think I've kind of gotten ahead of myself. Here's some further information about rehydration. And again, you want to intervene as early as possible because many of these patients are profoundly dehydrated. And again, you want to treat them empirically for electrolyte loss. There's 2 phases of rehydration. There's the replacement phase and the maintenance phase. And one of the things that we should do as an organization when we go out together and respond, we will have various protocols we'll give you about, especially the replacement phase, because you want to be aggressive, especially in malnourished patients. You want to be aggressive but not overly aggressive. So there are certain protocols that we'll follow, which I won't delve into here, that guide you in terms of the quantity of replacement. And generally speaking, in the replacement phase, we replace the fluids they've lost, give or take, within the first 4 hours, and then you go into the maintenance phase, and that's with ongoing fluid loss, because a lot of these people will have persistent diarrhea and electrolyte loss, and so you phase into the maintenance phase, in which you decrease the amount of fluids you give them, but you still have to make sure that you keep up with the ongoing fluid loss. We've already talked about ORS versus IV fluids. Again, patients that can consume fluids orally, that's the route that's preferable. The oral route is always the preferable route. IV fluids are reserved for those patients that are unconscious or for whatever reason can no longer, for example, maybe they have profound vomiting and they just can't consume IV or oral fluids. And then we've already talked about empiric replacement of potassium. Any questions? I'm moving kind of quickly here and I'm doing all the talking.
Now, most of the people listening or present took part in the cholera outreach in Haiti. And when you get an onslaught of patients like we got there, frequently we had to go by the ORS to IV fluids because just simply the number of people available to assist each patient. Whereas somebody watching IV fluids, you can watch about 8 patients. And keep that going. Whereas ORS is a one-on-one, thing when you're, care procedure when it's in the early phases of the treatment.
Right.
So you have to keep in mind what you're facing. When you've got 100 patients coming in, in a half a day. And you've got 20 people to manage them, it gets to be a different story.
It absolutely does.
Yeah.
Yeah. So Kelly Sykes makes a very good comment about glucose, and I haven't gone into that yet, but that's something that we certainly need to be vigilant about. Hypoglycemia. A lot of these patients have not eaten for several days, and so they're certainly going to be hypoglycemic. A lot of these regimens, may or may not have glucose. That's the beauty of ORS. ORS does have glucose. Patients that are profoundly hypoglycemic, they're certainly at risk for seizures. That's one of the most common causes of seizures is hypoglycemia, so don't forget that. Sometimes we have to give them a bolus of concentrated glucose, or again, if they're semi-conscious, if you can get some sugar in them any way you can, then it behooves you to do that. Oftentimes, we'll have a glucometer, but we may not. So you may have to maintain, good vigilance about hypoglycemia. So that's certainly a very valid point. Thank you, Kelly. Anybody else before I keep going? Okay, so, and again, I've already driven this point home, but I'll say it again. Antibiotics are not indicated for most children with acute watery diarrhea, but empiric antibiotics are for acute bloody diarrhea, and we're going to talk about that actually right now. So in terms of empiric antibiotic therapy, what antibiotics should you utilize? As a general rule, if you don't know the causative organism and you are dealing with acute bloody diarrhea, you should treat it as though it's Shigella. And there's several reasons for that. Number one is because often, if you just look at statistically speaking, many of the places where we will intervene, it very likely will be Shigella for acute bloody diarrhea. Number two, if you treat Shigella, many of the other organisms that you treat as though it was Shigella, they are susceptible to the antibiotics of choice for Shigella. So those are the two big reasons why. And the classic recommendations are to utilize fluoroquinolones for Shigella. Ciprofloxacin works very well. It's BID dosing, and the beauty of fluoroquinolones like Cipro, their bioavailability orally is just about as good as it is IV. So in other words, if you gave ciprofloxacin or Levaquin, if you gave them to a patient orally, they're going to be just about as strong as if you had given it to them by the IV route. So, and Shigella and many other of the organisms that cause acute bloody diarrhea are susceptible to them. Alternatively, you can use Zithromax. Zithromax also covers Shigella and a number of those organisms that cause acute bloody diarrhea. So now, hypothetical question. What happens if, let's say, you're getting 2 or 3 days into it and they're still running a high fever, they still have copious bloody diarrhea, and it looks like they're just not responding to your antibiotic? What's something that you should consider? The answer is right before us. HIV? Yeah, that's certainly a possibility. Generally, HIV in and of itself, if I'm not mistaken, does not cause bloody diarrhea. But that's certainly, but still, they're going to have more overwhelming infection. So if they do have HIV and a concomitant infection like Shigella, it may very well be that they have just such a large burden of organism that you're having trouble killing it off, or it may be that they have resistance. So I think about I think about antibiotic resistance, and I'd also think about an alternative diagnosis. So one of the things that I would highly recommend to everyone, if you do use, let's say, Cipro or Zithromax, and you're 2 days into it and they're not responding, think about an alternative organism such as, let's say, a very common organism is amoebic dysentery. And what antibiotic would you use? Would you add to the regimen? Cipro or Zithromax is not going to kill Entamoeba histolytica. Which antibiotic would kill that?
That's correct.
You're saying it. Say it louder. Someone said metronidazole or Flagyl. That's correct.
Mm-hmm.
So I would add Flagyl to the regimen. 2 or 3 days out, if they're not getting better, I would continue the Cipro or Zithromax, but I would add Flagyl to the regimen. that's good. There's also other organisms, like I said, like I can immediately think about schistosomiasis that is a bit tougher to treat, and it would not respond to those organisms. So here's one other critical part of treatment that we haven't talked about, or we just briefly mentioned, but zinc supplementation. So that's something that I would advocate. The World Health Organization likewise recommends it. It does reduce the severity and duration of diarrhea. It reduces the incidence of subsequent episodes as well of diarrhea for several months. So I'm not sure why that is. I don't know if anyone else out there knows, but it does do that. So you're improving their prognosis over the next several months. So it's very inexpensive and it's easy to administer, so it's a good thing. It's specifically meant for children under 5 years of age. If they're 6 months or younger, they recommend 10 milligrams per day for 10 days. If they're between 6 months and 5 years of age, they recommend 20 milligrams a day for 10 days. So remember zinc supplementation as part of your protocol for treatment of acute diarrhea. Okay, and then just quickly here, I think we've mentioned some of these points about malnutrition. So oftentimes these patients that we're going to be treating with acute diarrhea are going to be malnourished. Again, with really profoundly malnourished patients, that is like with patients with SAM, or severe acute malnutrition, you want to monitor closely because these patients have very permeable membranes and they're going to be a lot more susceptible to fluid overload. So you want to keep that in mind. You, again, want to use reduced osmolarity ORS, such as racemol in these patients. You want to avoid IV fluids at all costs unless they're in overt shock and you don't have any choice. In these patients, again, with severe malnutrition, you just, from the get-go, you utilize empiric broad-spectrum antibiotics, even if it is just acute watery diarrhea. And you want to be very vigilant. I'm not going to delve into a lot of discussion about treatment of malnutrition, but you certainly want to be very vigilant for malnutrition and treat their malnutrition in addition to their diarrhea. For example, you can use F75 and then graduate to F100, nasogastric feeding, for those patients that are not ready for oral ingestion yet. And I'll save that discussion for another day, or I'll recommend that you go back to the recordings when Julie Tanaka talked further in depth about that. That's a good discussion that you can listen to the recording. And then finally, infants with diarrhea should be encouraged, if they are breastfeeding, you should encourage them to do so. It certainly meets their nutritional needs, and it actually benefits them from an immunological standpoint in helping them to overcome their diarrhea. And then finally, there's many of these patients, like I said, they can be treated on an outpatient basis. But if you do have patients that are, that they're so profoundly malnourished or dehydrated, they may warrant hospitalization. And again, I'll go back to the old expression, a picture is worth 1,000 words. These patients, you can tell very quickly by just visualization that they're just not going to make it at home. So remember that option if it is available. The prevention, of course, we need to, any way we can improve sanitation in the camp, we certainly want to do that. We want to really emphasize education in regard to individual hygiene. And again, as Dr. Wood has pointed out, we're fighting years of cultural influence, and what may seem like, common sense or just natural, use of good hygiene to us, it may not, be culturally acceptable to them, or maybe they just haven't been educated, or maybe they have some good reason why they're not implementing appropriate hygiene. And so education is paramount. It can be a source of infection and diarrhea. And then I'm an advocate, certainly, again, of breastfeeding. It helps prevent development of diarrhea. And then if we had the funding, and it's relatively new, but vaccination campaigns against rotavirus. Rotavirus in the pediatric population is tremendous. It decimates many populations in the developing world. Again, if you see a child with pretty profound watery diarrhea and it tends to be green, think about rotavirus in a young child. And then finally, clean water sources, and then we've already discussed educational measures. And then just if you're in a situation where you're evaluating outbreaks, there's really, generally speaking, it's a subjective call, but there's generally no numerical threshold when you declare an outbreak. There is one exception, again, that happens to be cholera. And in cholera, if you have one patient with definitive cholera, that is an outbreak. I'm always careful to say, for political reasons, be very careful when you use the word cholera. I would never use that word unless it was confirmed diagnostically. And then finally, number 2, it says rapidly detectable rise in cases of acute diarrhea in a refugee setting. That is the making of an epidemic. You should really be vigilant to identify what are the potential sources that are causing this diarrhea. It may be one particular source, or it may be multifactorial. And that's where people like Dr. Wood, epidemiologists, come into play, or clinicians like ourselves. We need to hone in on our epidemiological skills and identify what is the source of the outbreak. And then finally, we want to maintain good medical capacity. Samaritans Purse wants to be able to have good surge capacity, and that's where you guys come into play. We may call on you guys if there's an outbreak. And then finally, I just want to close with, this is just another picture that I just took recently in South Sudan. That's just a hallmark picture of South Sudan. You see people with incredibly large items on their head, which I could never do, but they'll walk for miles and miles with these various items. But Matthew 5:16, it says, "Let your light so shine before men that they may see your good works and glorify your Father in heaven." So, you know, as an organization, I invite you guys, I encourage you guys, let's be innovative and think how are ways that we can intervene in terms of diarrhea, treatment and management of diarrhea. Some of the interventions, as I said, in fact, I think the best interventions we can make are simple, not so sophisticated, and we can have a profound impact on the number 2 cause of demise in U5 in the U5 pediatric population. So, with that, I'm just going to leave or open the floor to discussion. If anyone has any ideas or comments they want to make, experiences from the past. Any additional comments that they'd like to make?